My name is Jacob Petrosky. I'm a bariatric surgeon and a general surgeon who takes acute care surgery call and ER call. I want to thank SAGES for giving me the opportunity to present on this ever-challenging topic. The title of my presentation today is Jeep disease and how to manage acute pilonidal disease. I have nothing relevant to disclose. Historically, 1833, Herbert Mayo described a hair-containing cyst just below the coccyx. In 1880, the term pilonidal was coined. It's Latin for the roots hair, pilo, and nidus nest. During World War II, Jeep disease became much more common. More than 80,000 servicemen were hospitalized with this disease. It is believed that bumping around in a Jeep caused development of this disease. Pilonidal disease is difficult to treat. The treatment is complicated by morbidity, pain, limited and restricted activity following surgery, intensive wound care that may be required, non-healing and infections, recurrences, and low patient satisfaction. All of these factors complicate the management of this disease. Even today, pilonidal disease remains a significant malady. A single treatment modality has not emerged, signifying the differences in the spectrum of the disease at the time of presentation, as well as its severity. Generally, when a specific treatment modality is successful, it tends to become more utilized over time. The number of treatments is a reflection of the differences in presentation and severity of disease. Etiology of pilonidal abscesses, cysts, and sinus tracts is still poorly understood. There is mounting evidence that it is multifactorial. Originally, this was believed to have resulted from a congenital cyst at birth. More recent understanding of the disease is similar to ingrown hair development. Hair is forced downward, pushed under the epidermis, where it continues to grow. Moisture irritates the skin, and fluid may be pushed into inflamed and open hair follicles, creating a collection of hair, fluid, and foreign body particles that are a result of a foreign body reaction. To review the pilonidal anatomy, this is generally located in the midline, just above the gluteal folds. We have the epidermis, which is epithelialized in the most superficial layer of the skin. We have the dermis, the subcutaneous fat and tissue, followed by the bone. There's erythema and induration noted with an inflamed or infected pilonidal sinus tract with a cavity. The sinus and the cavity. This cavity generally contains hair, and hair was found in more than 90% of excision specimens. With the sinus tract is more likely to be epithelialized at the epidermis, preventing the sinus tract from closing and healing and promoting a chronically draining sinus. The cavity is not a true cavity. The cavity is not a true cyst. The cyst cavity does not have an epithelial layer, making it a pseudocyst. The fluid within the cavity is caused by a foreign body reaction, which is not completely drained due to the long sinus tract, which is typically thin. This prevents the fluid from draining out. Risk factors are male to female predominance. In the literature, it's 2 to 3 times more likely to occur in males. Younger patients present. The median age is 24 years old with classic pilonidal disease not presenting after age 45. Hirsute body habitus with thick, coarse hair, perspiration, smoking, obesity, and familial predisposition have also been implicated. In some, there may be a congenital skin pit. Depth of the natal or gluteal cleft has been associated. Repetitive minor trauma may play a role, such as occupations with sitting and driving, also office workers. More significant trauma is not thought to be a direct etiologic factor. It's thought that a significant trauma can inflame an already existing pilonidal tract and create new inflammation around the cavity, causing a previously asymptomatic cavity to become symptomatic. Presentation is variable, so scale. where patients may present without any pain at all. They may just present with a newly noted firmness, but no pain. Others may have intermittent blood or pus noted in the underpants, and they may not understand where this is coming from. Some may mistake it for hemorrhoidal bleeding. Others start to develop pain without any outward signs of skin changes. No sinuses may be readily available. There may not be any erythema or induration. Others will have erythema, induration, and they'll have sinus tracts with chronically draining fluid. Many times the fluid becomes infected, and once the underlying cavity becomes inoculated with bacteria, it may develop fluctuants and other signs of systemic infection, including fevers. Some patients may have their pilonidal cyst present for many years. They may be embarrassed to present, or they may think it's nothing. Here's an example of a chronic sinus. There are actually two sinuses here, or also known as pits. Close examination of the posterior is required. Initial treatment should be hair removal, sitz baths, and vertical scrubbing, which is a nod to hygiene. More recently, in 2008, Gibbs et al. Described a new procedure for excision of the sinus tract and debridement of the underlying cavity. They treated more than 1,300 patients. 59% were able to immediately return to normal activity, in contrast to patients who require wide local excision. 39% did not require any pain medication or analgesia following the procedure, and their early failure rate or recurrence rate was noted to be 4.4%. The way the procedure is performed is using a punch biopsy, also called a treffing. The treffings were used from 0.5 millimeter in size and all the way up to 9 millimeters in size. In the bottom left picture, you can see a cross-sectional view of the pilonidal cavity with multiple sinuses. The treffing was selected to punch out the epithelialized portion of the sinus tract at the epidermis. This was done in a perpendicular fashion to the skin. And once this was removed, curettes were used to clear the cavities and debride the cavity. Next, hydrogen peroxide was applied to the cavities in the tract, and cotton Q-tips were used. Patients were advised to shower multiple times throughout the day, and a continuous daily intergluteal dressing or packing was strongly recommended. Patients were followed up weekly until complete healing occurred. This is a relatively new approach for treatment of a pilonidal sinus with cavity. The next and probably the most common presentation for the acute care surgeon is going to be an infected pilonidal sinus. And at this point, one should consider that it's an abscess. So abscesses are generally treated with incision and debridement. In the example here on the right side of the image, there doesn't appear to be any open visible draining tract. However, there are some minor skin changes in which a sinus tract was probably present, which allowed the cyst to become infected, and then it healed over. In this situation, the clinical exam is the most important in making the decision to proceed with surgery or bedside IND. This can be safely done in the emergency department with the patient in prone position, or it can be done in the clinic as well. Generally, it's well tolerated. The way that I do it is I apply a 0.25% Marcaine solution, large volume, diluted to 30 mLs, and I'll interrogate the tract if there is one. Especially if there is a draining tract, I'll interrogate it with a lacrimal gland probe after anesthesia is applied. Using the lacrimal gland probe, I can identify the approximate location of the tract. If there's more than one sinus, typically I'll try to connect the sinuses and I'll use the route or the path of the sinuses with which to excise the skin completely down to the cavity. When I excise the cavity, when I incise the skin down to the cavity, I'll debride the cavity quite vigorously. I don't use epinephrine with my local anesthetic because if there's going to be any need for hemostatic agent such as silver nitrate, I want to be able to treat it there in the clinic, and then I'll pack it. In general, when there's a malodorous character to the drainage, I'll take a culture and I send it off for microbiology and for culture and sensitivities. 90% of these infected abscesses will heal up with simple incision drainage, marsupialization, and packing. I believe the most important aspect of this is marsupialization of the cavity as well as debridement of the tract. If you leave the cavity and it still contains infected matter or bacteria, or if you leave the sinus tracts, the epithelialized sinus tracts are able to repeat the process over again. And this goes back to the beginning of the presentation where the most recent thought process is hair growth into the tract as well as forcing of fluid or sweat into the hair follicle. If something's infected but it's widely drained or there's adequate drainage with packing, one may not require antibiotics. Recurrence rates are common. Up to the range of recurrence is 10 to 40% in the literature. In expert hands, recurrence rates after incision and drainage can be as high as 10%. Again, highlighting the difficulty in treatment of this disease. Repeat debridement may be required. Early follow-up should be recommended. Have the patient return to your clinic on a weekly or bi-weekly basis for reevaluation and to ensure that the abscess or the infection is well controlled and treated. If culture and sensitivity comes back with resistant profiles, change antibiotics as appropriate. And in cases of recurrence, re-incision and debridement with marsupialization can resolve 90% of recurrences. Don't be afraid of recurrences. Even in experienced hands, again, recurrences are as high as 10%. Another thing not to do is do not make this a bigger problem. Don't try to perform a rotation flap in the acute setting, especially when it's infected. Once you control the infection, whether it's with packing, incision and debridement, or just exploration of the sinus tracts and passage of a drain, such as a loop drain like a Ceton or a small Penrose, this will promote drainage and it can promote healing. I wouldn't try to do a wide local excision or asymmetric skin flap until the infection is completely controlled. Long-term management, again, wait until the infection is resolved. At that point, consider excision of the tract in the sinus, wide local incision before recurrence. After resolution of the infection should be considered. If the patient has a history of chronic draining and a new infection or recent infection, or if the patient has multiple draining pits and sinuses, this individual is someone who's more likely to have a recurrence of an abscess or infection. There's a variety of asymmetric skin flaps available, which largely depend upon the number of tracts, how long the tracts are, how close they are to midline, and how much coverage is necessary. After performing a rotation flap, one should make sure to close the tissue in layers. All of the sinuses must be excised, and the entire cavity must be excised. I would excise the tissue all the way down to the bone or to the sacrum. Close the tissue in multiple interrupted layers with horizontal absorbable suture, and then consider leaving a subcutaneous drain at the base on top of the sacrum, as the drain can help control bleeding. It can prevent formation of a hematoma and can prevent superinfection of the skin flap site. And then for the epidermis, consider something with a lot of strength. Typically, I'll use a horizontal mattress sutures, multiple interrupted. I'll leave the sutures in place for 21 days because of the tension on the skin, and to prevent dehiscence. I typically would leave the drain in place for 3 to 4 days. Some will use staples to reapproximate the skin. Either way, the most important thing is to excise the sinuses and the cavity. I want to say thank you again to Sages for allowing me to present on this topic. And for anyone who's watching this, or anyone who wishes to send follow-up questions, please don't hesitate. Send them to my email address listed below. All right, thank you very much.